It's Michael Pagel, Program Manager of Greening Healthcare, and I'd like to welcome you today to our comprehensive how-to guide to scheduling ventilation systems. Scheduling is a topic we focus on fairly often. There's good reason. It's because we're labeling it as the biggest and best opportunity for energy savings in hospitals and saves you both on electricity and natural gas use. We'll go through as much as we can fit into an hour in all aspects of how to schedule systems. So whether you're just getting started on scheduling or have nearly everything completed and there's just that one last department or section of your hospital that you're working on, we should be able to help everyone on the call today. Greening Healthcare is a program of the Climate Challenge Network with technical direction from Enerlife and a partner of CHES. We're funded in part by the Government of Canada through the IRF program. And I'd like to emphasize, please ask questions through the Q&A option. It's a lot easier to track and answer than it is through chat. And we also have a record of it after. So if there are questions we haven't answered, we can go back and check the Q&A, but we do not have records of the chat. The presentation is being recorded today, and the webinar and the slides will be posted to our site within the next few days on the event page. And you go to the next slide, please. Thank you to all our program sponsors and industry members. Just an amazing group of organizations and people behind the organizations here, and I hope people on the call get a chance to work with some of these great teams. And with that, I'm going to pass it over to the Executive Director of the Climate Challenge Network, Ian Jarvis, to go through the land acknowledgement.
Thank you, Michael, and good day, everybody, whether you're in the west of the continent or here in the east with where we are in Toronto. We begin every Climate Challenge Network event with the land acknowledgement. We do acknowledge respectfully the ancestral and unceded territory of the Inuit, Métis, and First Nations people that we share these lands with. We're meeting today on a virtual platform. I'm speaking from Toronto, Canada, which is the traditional homes of a number of nations, including the Huron-Wendat, the Haudenosaunee, the Anishinaabe, and the Mississaugas of the Credit River, and Toronto and the lands all the way from the lake and to the north of Toronto, subject to Treaty 35, the Toronto Sale Act, with the Mississaugas of the Credit River. And as always, we believe the work that you are doing and that we are doing together with you today must and should contribute to our shared responsibility as stewards of the environment. So thank you for that. Next slide, please, Amandeep. Picking up on Michael's earlier comment, setting the stage for this, today is a big deal. The scheduling air handling systems in just about every hospital account for the large majority of energy use in hospital buildings. So they're the biggest user, and scheduling those systems, turning them off, turning them down when they're not needed, is the biggest single opportunity that every hospital has to make substantial changes, to move up the benchmark chart, to record the kind of energy utility cost emissions reductions. We've come at this before at all kinds of different levels, and we refer you here. Go to our website at greeninghc.com. And going back to 2021, we've been presenting different aspects of this whole thing of how ventilation systems contribute to health and comfort, as well as to energy use and greenhouse gas emissions, what you can do about it. Within these documents or these reports, you'll find case studies, you'll find panel discussions with individual hospitals, what they've done, how they've done. Coming off this, we came to our March 4th this year event. Could we go to that? So 2025. Next slide, please. And our March 5th webinar, I know I checked the registration for this event. I know many of you were there, and thanks for coming back. And we had a poll there, and 61 of the participants there were good enough to complete the poll. These are the numbers that came into HVAC scheduling, and the question we asked first was, for each hospital, what is the percentage of the non-clinical? So clinical areas can also be scheduled, but here we were just focusing on the low-hanging fruit. The non-clinical stuff should be easy. So what percentage are currently scheduled during unoccupied, low occupancy periods? And you can see the results there. 24 out of, was more than half the total response. It was less than 50%. So we're doing less than 50% of the measure that is the most productive, can deliver the most utility cost savings, the most emissions reductions of every measure there. So that came back to, we asked a number of you why, and they came back to, we're not sure how to get started. We get the idea and it makes sense, and of course we want to contribute, we want to help. We don't know how to get started, and that's how Michael and Amandeep came up with the idea. We need to go a bit deeper, a bit more granular, and let's put together a how-to guide. So today is all about how exactly do you get started, what are the steps, who should be involved, and a lot of thoughts gone into, and a lot of the experience we've drawn from you folks has come in. But we're tackling the single biggest opportunity, and less than half of you is doing as much of that as should be happening right now. So that's our starting point. Next slide, please. So putting together today's session, that same survey, that same poll, and once again, thank you everybody for taking the time to respond, because we rely entirely on your feedback. We asked first about code. And so the codes, the little 0 to 1 and 2 to 3 down there, 0 to 1 means it doesn't matter or it's not that big a deal. All the 2 to 3s are, it's a big deal or it's completely stopping me. So we're interested in the 2 to 3s. So within code compliance, 22 of you said that you've got that, you get it, that it's not getting in the way. But 17 said you're not going to move forward until you're satisfied on the code. So Amandeep's put good content here today around what does ASHRAE say, what does the Canadian Standards Association say. So we've addressed code. Dealing with occupants, and Daniel, thanks for joining us today, because the work you're doing with the clinical staff at Long Island Jewish Medical Center is exemplary. Like, it's building on everything that we've ever done before, but concern about the occupants not being very happy with scheduling. I'm used to coming in on Sunday and now I haven't got air conditioning. 11 of you felt that was getting in the way. The technical requirements, the infrastructure, the volume control devices, so the technical issues around infrastructure, 14 of you felt that you weren't sure how to address those. We've got a lot of content today on that. But it takes staff time, and I'm sure, Daniel, you'll speak to this. This is not something where you just pass it off and ask somebody to do it for you. It involves your staff, and your staff are busy and beyond busy already. So staff time is a big deal. 15 of you felt that you hadn't got the internal resources. And we asked a few questions around other, and some were quite detailed. I recall Sam, I'm not sure if Sam Hutchingame from Winchester Hospital is here, but he was concerned about one air system serving multiple areas. I think you'll find Amandeep's and Daniel's comments around this would be helpful. So these were what you told us gets in the way, all the 2 to 3s. This is what has been folded into this webinar today. We hope you'll find it useful. And we will be coming back to many of you. Did we get it right? Did we nail it for you? Can you move forward now? Because greening healthcare is all about moving forward. We've got to be taking action. We've got to be lowering emissions. Next slide, please. So the agenda, we'll start off with how big an opportunity is this, and it's big. The whole need to document what you've got, what the codes are saying. Amandeep's pulled together a number of scenarios: administration spaces, laboratory spaces, those kinds of things. How do you figure out what you need to know at the departmental level on how they're actually using the space? The big subject, how do you engage your clinical team, get them to be not just compliant, but supportive? And finally, what kind of resources are out there to help? So this is what we're going to try to work through today. Next slide, please. So your biggest and best opportunity, over to you, Amandeep.
Thanks, Ian. Good afternoon, everyone, and good morning to some of you folks. So, the ventilation systems, as you probably already aware, they impact every component of the energy use in your building, whether that's your electricity or a gas, and then you can look at the subcomponents as well. So anytime you touch a ventilation systems and optimize it or to reduce or to set back, it's going to help you reduce your electricity consumption in the building. It's going to help you reduce your gas consumption through reheating, through preheating, humidification, and on the electricity side, it's going to reduce the fan power and the cooling electricity as well. So these measures directly impact every single component of your energy use in the building. The size of the prize, again, it depends on your organization, depends, but it is significant. Just a kind of a case study coming from 6 hospitals that are currently either on the path or actively pursuing these measures. You're looking at the paybacks for these measures could range anywhere from less than a year to close to 2 years. So most of these paybacks are determined by the infrastructure that you have, but typically that's the range for these kind of measures that we'd expect when you set a hospital to follow setbacks on these. In addition to that, you also get, not only you get the energy savings, which is an obvious, but there's a component that comes along with this. You get a code compliance as a result of that. You happen to have fixed the issues with the comfort and indoor air quality, which we'll talk about. And then most of these measures, we expect a minimal infrastructure upgrades, if any, needed to implement ventilation setbacks in a hospital. Typically, when the schedules or the systems are not set up, you tend to see obviously the energy consumption is high in these facilities, but also there's additional issues that comes with it, that you have drafts and cold comforts as a result of overpressurization of these systems. So scheduling not only sort of minimize those, but it also helps to overall reduce energy and in fact demand in your building as well. So those component, I think, if going back to the couple of slides back, like if you want to kind of get more detail about build a case to why this is important, there's other webinars that you can actually reference. We talked about a lot about this, but today we're going to focus on how you can actually make this happen and how you can do it. But the benefits around reducing energy, benefits around fixing the building, benefits around providing extra comfort to your patients is always going to come along with implementing the ventilation scheduling measures. So now that gets into details around typical scenarios that we currently find in when we talk about setting up our system to be set back, or whether it's scheduled off or whether it's set back in terms of using the VFDs. So you have situations where they are a handling unit serving unoccupied zone. It's a single zone kind of, and then you have one AHU serving that zone. Those are the easy ones to set back or to schedule because there are not much complications around adding more infrastructures. And we'll talk about that in few with a couple of examples. Mixed zones are ones that have zones where a single AHU feeds a department which is unoccupied after hours, whereas it also feeds a department which is occupied 24/7. Then you have AHUs where they have variable air volume boxes that you can use to schedule certain spaces. And those AHUs could serve department which are occupied 24/7, or they could also serve combinedly department which are not occupied 24/7. So how do you do the scheduling for those? So we will talk about these scenarios. And then a unique situation comes also with a lot of the older hospitals where there's still steam coils, and we do see a lot of those in states. A lot of the AHUs have still a lot of steam coils. So how do you actually reset a system, especially in a cold weather where they have steam coils and there's a potential for freezing? So we'll talk about those as well. Before we do that, let's talk about the whole process. Like if you were to take anything away from today's session, this is one of the things we would highly recommend you to sort of follow this process chart that kind of help you define what to do first, what to do second, and how do you sort of get from point 1 to point 10 in implementing the schedule. This is your typical process of AHU scheduling and setback. So let me see if I can. Yeah, it starts with sort of forming a team. And that is sort of essential to set this stage for this project. Because once you have a good team with engineering lead, facility staff, clinical support, you can actually start working on the next steps. Without a team, it's really hard to put together the emphasis, because then then the project is not assigned to somebody, and you're sort of trying to do certain things that doesn't align with the overall process. And we've seen so many times the projects have failed because it didn't follow through that process. And this is kind of the process. We've come through learning from a lot of the hospitals that have implemented these measures, and we're trying to document this time. So you form a team, then that team helps you define a scope of work, which basically sets what are some of the departments that you're going to start earlier, and get early wins on those departments by setting them back. And then who are the people that you're going to involve? What are some of your goals in terms of the energy savings? What are some of your goals in terms of the compliance? Is going to be determined once you kind of get that team set up and they start working on through these defining scopes and objectives. The key part of this is that we also want to make sure that you get the incentives in place for all of the measures that you're doing, because you can recoup a lot of the cost or investments as a part of the incentives. And we'll have a bit of more detail on the incentives when we go through the slide deck towards the end. But some of them, the ISO as an example, does require you to put an application upfront. In that case, you got to have that application as once you determine the scope, then it's easy for you to put that application through. Then you kind of lead through the other steps, which some of them we'll talk about in detail today, around developing HVAC zoning drawings, mapping out the HU schedules, collecting the baseline data for your handling units, including trend logs and runtime hours for these, so you can set up which is going to be used for your incentive applications as well, but also M&V path as well. Clinical engagement, we're going to have a conversation with Dan today about how he's engaging his clinical teams to kind of empower this whole process. But it's a key step in ensuring that you get the right clinical folks involved and their buy-in, and help them understand why this is important. And then it takes you to actually finding and finalizing the details on HU scheduling, setbacks, zoning, determining the operating modes for each of these HUs, and then finally working with your controls contractor and the team to implement these measures, and then closing it off using an M&V, making sure that you achieve those savings. So sometimes the savings are large enough that you'll see those on the utility meters, so then you can follow then option C of the M&V. But sometimes the savings are not enough to start with, as you do sort of a couple of projects initially. So then you can just look at the VFD speeds and to make sure that the actual schedule has been implemented, and then you can see the drop in the VFD speeds as you do them. So this is sort of a defined process that we hope that once you start on this path, that you can sort of use it. And we always welcome a feedback if you find anything that's would be sort of an added information to the members and non-members. We would appreciate that comment back. Now let's look at the scenarios we talked about, which is kind of getting now deeper into this conversation, AHU serving unoccupied zones. So this is a simple scenario where you have a single AHU serving an unoccupied zone, which are serving a department which has an unoccupied zone during the after hours. So that in this case is a learning center as an example. So we picked up, so this is an administrative kind of a space which only operates from 8 a.m. to 5 p.m. Monday to Friday. There's nobody there after 5 p.m. and there's nobody there on the weekends. So this one single HU unit, single zone, you can actually schedule or set back the whole unit, making sure the temperatures and humidity and pressurizations are addressed as you sort of set back these spaces. And we'll talk about individuals. This kind of fits into more of an administrative space, and we'll talk about that in a second. So that's one scenario. Then the second scenario is where you have mixed zones. That's the same HUs feeding a 24/7 operations, and then the same unit is feeding an unoccupied. So in this case, as an example, this is a unit that feeds the human resources department, which is only occupied Monday to Friday from 8:30 to 4, whereas an inpatient mental health is 24/7. So this is where now you start to sort of look into what sort of infrastructure you have. So if you have a VAV box as an example in these two departments, you can use those to schedule the human resources department and then rebalance or sort of leave the inpatient as in 24/7 operations. If you don't have those VAV boxes, then you're looking at an upgrade to infrastructure, which is basically mapping those ductwork to find what is the main branch that serves the human resources department, and then you can install a flow monitoring device, a VAV box or airflow monitoring stations to set back that particular area during the unoccupied period. So that's where you can reduce the air handling unit speeds by sort of dividing these two zones into through a minor upgrade of adding a VAV box or a single VAV box or a couple of sort of airflow monitoring station on the main branches. The third scenario is that in cases where you have a VAV boxes and it's connected to either departments that are 24/7 operations or departments that are the same HU serving a clinic which is not 24/7. So in those examples, then you can actually use a VAV box to close or sort of set a setback on individual spaces through a VAV boxes. And then the other department, which is occupied 24/7, could be remain as it is. By doing that, what happens is that the system should build up a pressure as you close these boxes after unoccupied or during the unoccupied period, and which would ultimately reduce the speed on the fan. Some cases we notice that by even closing the boxes, the fan speed doesn't get lowered. So then you have to sort of look at alternative programming for those systems, because what happens, there are leaks in the ductwork. So even though we're closing the boxes and trying to build up the pressure to in the system, but the pressure is not building up because the air sort of leaks in other areas. So in those cases, then you want to make sure that you still get the benefits of setbacks, but then you have to reprogram your air handling unit slightly differently to get that benefit and not keep pushing the air through the leaks in those cases. The first scenario is commonly come across is their older systems where you have a steam coil as a primary heating source. And then especially if you shut down these systems during colder seasons, we tend to see there sometimes freeze-start trips happen on these units. So there are provisions to make the system go to unoccupied mode if especially serving the area that are unoccupied during the after hours. So you have to take few steps to make sure the system works. You want to make sure the preheat valves open up earlier during the startup, ramp the fans gradually. You can relocate the freeze start close to the cooling coil. You can also drain the cooling coil if it's not a lot of work at your end. And if everything doesn't work, then you can actually run the system as it is in extreme cold condition. But then you can probably 75% of the time, when it's not extreme cold condition, you can use a programming to ramp down the system or even to shut down the system during those unoccupied period. And then eventually when the units get replaced, hopefully it's get replaced with a hot water coil or glycol coil, then you can put a full mode HU setback on these kind of systems. So those are sort of the four type of scenarios that we typically see. These are some of the space requirements that are recommended or by the CSA and ASHRAE standard 170 CSA Z317. You can also reference these through those standards, which is to put a high level list of sort of a categorization of these spaces. So CSA categorizes them as type 1, type 2, type 3, whereas ASHRAE categorizes them as sort of a class 3, class 2, class 1 in a reverse order in terms of the critical nature of these spaces. The temperatures that are kept like sort of recommended for each space, we would recommend them to maintain those temperature range during the unoccupied period, and similarly the RH range during the unoccupied period. And then relative pressurization has to be maintained for these different type of spaces, and they have different requirements as you kind of walk through determining what space is served. Typically the type 1 spaces are critical care like ORs, delivery room, isolation rooms, and then you go to the type 2, which is your lab, pharmacy, outpatient clinics, diagnostic department, and the type 3 is your administrative spaces, offices, clinics, some of the clinics, and cafeteria and all of those spaces. So these requirements, again, we haven't sort of exclusive list all the requirements, but it's a good reference to go back and check the CSA and ASHRAE standards in terms of the requirements, and then try to work with your team to maintain those during the unoccupied period as recommended by these standards. So we have sort of looked at department level details to kind of explore this idea. How do we want to address majority of the departments in an hospital. So this is kind of an effort to do that. So I'm going to go through a few slides where we'll talk about different departments and some of the key lessons that we learned through feedback from the hospitals around challenges they've faced. And let's start with administrative offices. These are the kind of categorized as some of the easy ones to set back as very similar to an office space. Administrative spaces have least requirements in terms of the ASHRAE's 170 or CSA 317.2. So what you're looking for is to make sure that the space is reset back when the occupants are there. And then you allow for more morning warm up and pre-cools on those spaces. And then you enable the setbacks to make sure the temperatures range do not drop during the unoccupied period. So these steps are typically kind of recommended, and you will see a repetition of step 2 to 6 throughout the next few slides as well. But basically, you start with an investigation of the administrative spaces, determining what are some of the code requirements, what are some of the, if there's any pressurization temperature requirements. That's what your team's going to help you kind of determine those, confirm the hours of operations, confirm the hours of operations of the HVAC system that's currently doing. Then you start working with your BAS vendor to start documenting what are some of the programming updates you do have to make. Is that going to happen at a zone level, or can we make this at a AHU level? Then you determine what your range is going to be for the temperatures and your reset logic when the temperature goes out of these boundaries. What is your reset logic like? That typically involves, if you have a VV box, you start to open that up and then you ramp the fan up afterwards once you start. We're trying to meet that temperature range in those cases. And then in cases when the system is completely shut down, you want to have sort of a predictive start stop or smart stop, what we sometimes call it, to bring the system earlier to make sure that on warmer days or on colder days, the comfortable space set points are met before the occupants in that space shows up that morning, especially during a shutdown over the weekend. You want to make sure that you allow enough time for your system to recover during those times. Then keeping an eye on the freeze protection for, as these systems may not have been shut down in the past. So now you're setting either setting them back or shutting them down. So the freeze protection comes in handy because one system comes in, especially during the colder startups, you might see sometimes there's a freeze trip as a result of that. So ensuring that you looked at the freeze protection off your seconds off your air handling units is a key to make sure that you don't get these nuisance freeze traps, and it's already in your process to make sure that it's done as a part of your steps when you kind of implement these measures. And the last but not least is the M&V process in this to verify that it's actually working. The best verification of the setback is working. You're looking at a VFD speed, that it's going from an occupied period and down to an unoccupied period and then coming back in the morning. So that expected VFD turn down ratio is there, and you have to prove that through the trend analysis is the key. So then the other type of spaces is ambulatory care that you see are one of the other ones that are more typically not occupied after hours, so which includes your outpatient clinics, your minor procedure surgeries, your dialysis, the day surgeries, and recovery area. All of these areas, they're designed as from the clinical side to be operated with the staff being there typically from 7 to 5 or 5:30 or 6. But after that, they're not scheduled. So after that, they could be scheduled to a setback mode. However, these spaces have their own requirements because now we're going into type 2 and type 3 spaces as we get into ambulatory care or diagnostic imaging departments. So the key the key things, there's other things, but the key things that are documented when working through these ambulatory care spaces is to ensure the sterile storage check, like where are they storing, especially if it's procedure rooms, where are they storing those sterile equipment? Are they storing them in a sterile storage space? Is it stored in a corridor? Is it stored in a procedure rooms? Because wherever they store the sterile equipment during the unoccupied period, that space automatically kind of becomes a sterile storage space. So now you have to make sure that it is the air change for that space is as per according to the sterile storage area, not for that original intent of that space, because the sterile storage, the sterile equipment is to be stored in that environment for that minimum air change required. Similarly, the environmental cleaning schedule has to be coordinated to make sure that you don't bring your system on when somebody comes in, or your system is there to be performing as the cleaning is happening, and then you can reset your system or set back your system after the environmental cleaning is done. Similarly, for the procedure like type 1 sort of procedure rooms, you want to make sure that the pressurization, RH, and the air change rates are met for those spaces during the unoccupied period. And in cases, so as an example for ORs, which we'll talk about, the recommendation, even procedure room, the recommendation from the CSA is to kind of lower their air change to 6 air change rates. But in some cases, you can't get the pressurization at the 6 change rates. In those cases, you actually have to go higher than 6 air change rates to make sure that pressurization relationships are still maintained in those spaces. Once you determine these in an investigation phase, then the step 2 to 6 is very similar to administrative spaces in terms of the programming, resetting temperatures, and M&V. Diagnostic imaging in most of the hospitals, there is a component of diagnostic images that's going to be 24/7. However, there are departments that are actually not, there are rooms in this diagnostic imaging that actually are not occupied 24/7. So this setback is actually going to apply to those diagnostic imaging spaces. Here's an example of, you could see that the stress test area during the unoccupied period is not occupied, and even the echo is not occupied in after hours. X-rays are occupied 24/7. Similarly, you might have MRI, which is occupied 24/7, or a CT is occupied 24/7. So this kind of is in a DI space, and it generally applies to every space in a hospital. You would have a combination of areas where there are spaces that are 24/7, whereas other spaces within the same department are not 24/7. So you can actually schedule the other spaces or set back those other spaces in those departments. For the DI specifically, because there's a diagnostic imaging equipment, you're going to want to ensure that the environmental conditions for those are investigated with your diagnostic imaging clinical team to make sure that those set points or the set points that you apply do not impact any of those medical equipment. That's a key. And then the focus again is on making sure the administrative spaces in the diagnostic imaging are focus of setback in this department. Kitchen food services, again, another area that's not occupied after 24/7. Typically, this would have a makeup air unit that's required for the kitchen exhaust that comes on as or remains on 24/7 if it's not set back in your hospital. But there's opportunity to set back these systems. These systems are typically either would have a steam coil or a glycol coil. So the freeze protection is a much more important concern here in the kitchen and the food service department. So this coordination between understanding how your kitchen is currently used, what are some of the clinical sort of cleaning hours, when do they need the exhaust, when they don't need exhaust, who's there after hours, is there anybody after hours? So those piece of information has to be documented in an investigation phase. Once you document that information, then you can align the step 2 to 6 within what's going to be a similar administrative sort of spaces. Controlling the piece of M&V and programming is all similar in most of the cases. Cancer clinic and oncology department is another area that we notice is unoccupied after hours. However, this department does have some special areas like a compounding pharmacy and a clinic units, which need special attentions when you optimize these systems. So an example of this, like you will see a bunch of treatment rooms here. That some of them will have clinic units, some of them are just the treatment units in for the medication only. So the clinic unit in cases depending upon the treatment, they become type 1 spaces. So you got to make sure that the temperature, RH, and humidity are maintaining these spaces during the unoccupied hours, and your reset is compliance to the code requirements in those cases. But there's many sort of areas in the spaces which are just the clinics that could be reset. And even the Linux, you can reduce their flows in compliance with the equipment requirement and in compliance with the temperatures and humidity requirements. The compounding is another one that's, again, you got to make sure that you work with your pharmacy in the compounding areas, because they mix. There's fume hood, there's anti-room for that area, so that pressurization has to be maintained all the time during the unoccupied period. And those areas have to be investigated, air tested pre and post to make sure that your compliance with the pressurization requirements for these spaces. Again, with the lab and pathology departments, the lab, there's functionality of the lab typically called as a core lab, which remains 24/7, because as you get the samples throughout the day and 24/7, that has to be processed. However, there are many spaces in the lab itself that actually could be scheduled to set back. There's offices, there's lab in the pathology area that gets unoccupied during after hours. So those are the key areas or focus areas for labs. So the labs, again, it comes with its own sort of complications, because typically the labs have an equipment that generate a lot of heat in there. So you got to make sure the temperatures are kind of maintained when you do the unoccupied mode. And also there are exhaust requirements for the labs. In some cases you have fume hoods, they have biosafety cabinets that are continuously exhausting. So ensuring that the conversations with the lab folks to ensure that these areas are documented first, to understand where you need a continuous exhaust, where you don't need a continuous exhaust, if they're storing anything in the fume hoods during the unoccupied period, and what sort of pressurization is required as a means to before you start implementing any of the setbacks in the labs. But again, the opportunity is there in every department. We just have to make sure that the compliance is there in terms of the clinical requirements for these spaces. Pharmacy, we touched on. There's some cases. There's also compounding happens in certain pharmacies. So looking at the pharmacy area, so there's kind of an example. There's a big area. You have a lot of meeting spaces. There's some core workbench stations in the library area. There's some meeting rooms, offices. All of these, again, areas that could be set back during the unoccupied period. Again, the key things around pharmacies to ensure that where they're storing their drugs and what sort of temperatures, humidity range do they need during the unoccupied period, and what are some of the requirements in the pharmacy around if there's a sort of a compounding area that they're mixing drugs and where they're storing it. So keeping those in mind when you're looking for setback in these spaces is going to be critical to make sure that none of that clinical requirements is jeopardized while doing the setbacks. Surgical suites, we heard a lot about. There's a lot of attention that we get from even the clinical folks around. There's doctors who are taking initiatives to set back ORs when they're not used, and typically these ORs they consume a lot of energy when they're running at 20-year change. In some cases, a higher air change rate. So ensuring that the CSN and ASHRAE does allow you to reset these ORs to unoccupied mode. However, just to make sure that you have a full coordination with the clinical folks, because typically you would have in a larger facility setup, you would have 8 to 10 operating rooms, and only probably a couple of them are used during the unoccupied period. You can actually set back the remaining ORs to unoccupied mode operations, and then you can leave those 2 other ORs as a full sort of 24/7 operations that they can use during the emergency surgeries that happens as a result of any accidents. So the key is to have a combination, sort of a clinical engagement early with the ORs, to helping them understand why this initiative is important, and then determining the space requirements, where they store the sterile equipment, and applying those principles of each of these spaces to ensure that you get the right temperatures, setbacks, and humidities and pressures for these spaces. All right, let me bring in Dan, because this is the clinical team engagement is a key piece to this. Before I kind of had Dan in 1 second. Michael, I was going to ask you if there's any questions we want to address now before bringing Dan.
Nope, you're good to keep going.
Thanks, Michael. And again, just remind everybody, whatever questions you have, please feel free to fill in the chat, and we'll definitely address them either just during this conversation, or we'll have a written response to those. So feel free to bring in your questions as we kind of have these conversations along.
You
Dan,
did
thanks
Q&A, right, Amandeep?
Sorry, Ian.
The questions go in the Q&A, right?
Yes, did I say no? Okay, yeah, question goes in the Q&A. So yeah, if you have any questions regarding any of your own concerns when we implemented or try to implement these, please feel free to put those questions in, and we'll try to address those as we have this conversation. So been joined with Daniel Scott. He's the Senior Manager, Facility Management at Long Island Jewish Medical Center and Northwell Health. Just for the context, Northwell Health is the largest provider in New York, and LIJMC is one of their key facilities that Dan and his team's working on. So Dan, maybe I'll start with you with very high level questions. Your clinical engagement with your team, can you kind of give us a bit of a background around when this project was initiated to you with the setbacks, and you brought this idea to your clinical folks? Like, what was their response initially, and how did you manage this whole process of engaging them into this conversation about setting back some of these HVAC systems, which are currently not operating 24/7?
Thank you, Amandeep. Appreciate it. Just want to thank you guys for letting me join and give our experience here at LIJ. Like you said, there's a lot of challenges that come along with these fan setbacks, and Life definitely provides the solutions to make that move forward. Like you mentioned, bandwidth of the staff, occupancy of the spaces, and the coordination of code and compliance is huge. But really bridging the gap between the clinical teams and the engineering vision that we have in mind is probably the hardest. Creating a team that defines roles and responsibilities was the first and foremost step that we had to take. But together we decided that setting out a survey to the clinical team was probably the easiest way to get their feedback and be able to collect their input, which has been great so far in our endeavor and moving forward with this project. So getting their feedback and taking that and digesting it and coming up with a plan with the team to move forward is probably the best way that we made this work.
Thanks, Dan. Typically, one of the questions that get asked or sort of addressed is the clinical teams. Like, there's a presumption in there, like there's a pushback from clinical teams around setting these systems or setting them or resetting them. Like, have you encountered any to date so far in terms of having those conversations with them, and what was their reactions to this?
Yeah, you do get initial pushback initially, but really explaining to them what the purpose of this is kind of hits home, and they they understand after we provide a one pager that is on the screen now to understand why this matters and the impact and the savings that's in return.
So once you've done that, there has been a lot of good response, to my understanding, from the clinical teams. Like it, and I think one of the things I want to point out is that the importance of engaging them. Like what you encounter, like there's a lot of things as you talked about the surveys. Here's a couple of sort of for audience that out there. This is a sample of how the survey kind of looks like that was sort of shared with the clinical teams. There's a lot of knowledge that exists with the clinical team that sometimes we don't initially see coming from the facility side. Like, do you have any sort of insight to share where we're seeing a feedback coming from them, from the clinical teams around their systems, right? It's how did you find that engagement so far in terms of engaging them so they understand that process, but also making sure that the information that we want to collect from them around their clinical departments, around their operating hours, around their special rooms, like that becomes a key documentation process? Like, what's your sort of, like, you've been floating this sort of surveys to them today. How did you sort of find the surveys working out so far?
Yeah, I think the initial response or the initial the initial feedback that you get is they're concerned about compliance issues. But once you communicate, communication is key to the clinical department. Once you communicate to them and provide that survey and the one pager, they get a true understanding of what we're looking to do, and they usually come back with comments that we initially didn't expect, or they catch things that sometimes are fall through the cracks.
Thanks. And then as you sort of go through this process, then I think the buy-in becomes much more easier, right? Once you, especially when you implement something and it goes sideways, they know they're part of the team as providing a solution rather than pointing fingers like we told you this is not going to work. But now they're kind of, okay, yeah, we understand why it's happening, and this is an important piece. We want to get involved and excited about it.
Yeah, there are also areas that are harder than others. We kind of started with the harder units that serve multiple departments or multiple areas in a building. Trying to get that coordination was difficult. So that's when we decided on the survey to kind of bring everybody's responses back to one common place, and then try to divvy up the responsibilities from there.
Okay, one last question. So Dr. Bartak has been sort of pioneer in kind of engaging your clinical side. How did you find that finding a champion on the clinical side helps you actually make this work much easier? Like, what's your recommendation for the folks out there? Look for their champion within their organization that would help them set the stage for the clinical engagement.
Yeah, definitely having a clinician on. Right now, we have a clinician that's on the Sustainability Act, and having his input and being on the clinical side is huge. Whenever we do have difficulties reaching departments, and the feedback doesn't come back as quickly as we need it to. Everybody from administration to engineering to the operations team. So it is a group effort that initiating that team, like Amandeep has said in the beginning, is key to making this a success. So and also dividing up roles and responsibilities right from the beginning is important too.
I think you have your consultants involved as well, right?
The consultants are involved as well, yes.
Excellent.
Awesome. All right. Thanks, Dan. We'll thanks for your time. We'll continue to engage with you as this becomes a much broader exercise, and hopefully leverage some of the work that you guys use and share with other out there on the call. Thanks again. All right, continuing with this, another key piece of this is to leverage the incentives out there. So I see a lot of our ISN and Enbridge folks are on the call today. But there are many initiatives out in different provinces, and even New York has a lot of incentive programs right now that are currently being leveraged to do a lot of this work. So we would highly recommend you, I'm not going to go through the details of this, but what I would highly recommend you, if you're not using incentives right now as a means to offset some of your costs towards implementing these, I would highly recommend you to reach out to the respective parties, which includes ISO, Enbridge, BC 4Days, and other that are actually leading these initiatives. Incentives are great at this point, so I would highly recommend you to sort of consider these incentives for implementation that would offset a lot of your costs in upgrading these systems, and it makes the business case much more easier to implement. We understand how resource and financial resource constrained the hospitals currently are in this environment. So this kind of helps you to set the stage and to help you sort of implement these measures through these incentives. So last but not least, again, I want to make sure that this is what you one of the things you take away through this is is the process is more important in this than other details. That's the starting point for this project to ensure that you get the right process in place and every detail will fall in place. So I'm going to repeat this, but these 10 steps is something we seem to work for the hospital that are trying to implement these measures. So we would recommend you to consider this as your starting point to sort of work through engaging your team and then following these steps. And again, we would want to learn from you as you implement these. And if there's any feedback for us to incorporate and update this table and this chart, we would love to see that coming from folks that are actually implementing this. And then the details around all of these, and we're going to cover a lot of the other contents over the years as well in the next few sessions as well. So anything that is an interest for organizations out there, we'll happy to connect and provide more details as well. All right, that takes me to Michael. Do you want to take any questions?
Yep, we can go through a few of them. Did you see any pop up that you wanted to start with? Or you want me to pick?
Let me take a look at it. Give me 1 second. So there was a question around what's in for clinical team to reduce energy consumption, to reduce energy cost, and to reduce carbon footprint. Dan, happy to feel free to chime in if you have any thoughts on that, Anine, as well. I'll give my 2 cents. I think when we think about clinical teams as folks that are delivering healthcare, but actually they also are getting every day impacted by what's happening with the climate change. So they also have a passion for reducing emissions in there. So they're passionate about these projects. I mean, yes, their day-to-day job is to provide healthcare services, but they also have a community. They also have families that are getting impacted with this, right? So for them, it becomes an important initiative because they're actually contributing towards reducing emissions and reducing energy in a healthcare facility, and then it overall impacts the whole society.
Yeah, I'd echo that, Amandeep, that over the last less than 5 years, clinicians have been part of the problem, and they've transitioned to they're pushing us now. And there are Dr. Bartoks in hospitals we're working with across North America that get this stuff. They want to contribute, they want to help, and they want to work with the facilities teams to make these things happen. So I think many of you heard from Dr. Anita Rao, our keynote at the 2024 annual forum. She's an anesthesiologist that leads the charge at Trillium Health Partners, one of our biggest healthcare organizations, and clinicians for the environment. They are pushing, and they're pushing us now. So that's been one of the biggest changes I've seen in the last 3 years.
Thanks, Ian. There was another question around how to map the individual independent exhaust fans and pressurizations in a department when you're trying to set back a particular area, which is unoccupied, whereas the other area is occupied. I think the general answer to that is, I mean, there's specific probably answers to each situation, but the general answer to that is air testing and balancing. So ensuring that they're scheduling projects do air testing and balancing to make sure those compliance for pressurizations are maintained, and the solution is going to come as a part of the air testing exercise that you're going to do when you implement these setbacks. So the exhaust fans, yes, they're key to making sure the pressurizations are maintained, but it's gonna get it sorted when you try to do those try to do those pressurization tests while implementing pre and post.
I'm looking at the clock. Can we respond to the other questions
Absolutely.
after the event, which we will do if we've got the contact people, which we do?
Absolutely.
And let's look to finish on time. Maybe I could pick this up that greening healthcare. We've got 2 more events coming up in 2025. October the 15th, there's another webinar, very similar format to this, but looking at procurement. So the whole procurement question is a big deal. How, as you're trying to change to a low carbon future, traditional procurement models don't always work. They tend to favor like for like and doing what we've done before, and we know we can't keep doing what we've done before. So do join us on the 15th. November 24th is our annual forum. It's the Western Harbour Castle. This is in person, and we welcome people from across North America coming to share at the strategic executive level. The challenge is where we are, why this matters. We'll have a keynote, which is generally a hospital CEO. So all the way from the C-suite, as it says, down to the boiler room. There's something in this for everybody. And what Amandeep was saying earlier, hospitals get this. Hospitals are right in the nexus of climate change and the pressures of dealing with the health consequences. So the strategic event every year sets the stage for the following year. It sets our program, and it really does, I think, inspire and help people kind of get their heads around the big picture and keep things moving. So these are our two remaining events this year. Again, you see the website address, the previous workshop recordings that Michael referred to earlier. They're all there. There's a wealth of stuff in the library at that website, and including around scheduling. So this is what that's to come. Next slide, please. The greening healthcare gets its strength from its members and its industry partners. It's really that simple. We have government, industry, and hospitals, big corporations and small hospitals all working together on common problems. The general message from greening healthcare is we've got way too much to do in too little time, and with too few resources to keep reinventing the wheel across North America. We need to work together, and greening healthcare provides a forum where everybody can come together, share as we are today, but share experiences, share case studies, share best practices. We learn every time. We will be following up with a number of you today, because every one of these events we learn from. You have angles and perspectives and experience that contributes to the whole, and then we try to process that and bring it together in future events. So if you're interested, we'll give you Heather's contact information in a moment. She directs our program and partnership development, and we'd love to have you join the conversation. Next slide, please. So here's the contact people. We've, as I mentioned, Heather is our Director of Program Partnership Development. Please do contact her with no obligation. If you just want to learn a bit more about what being a member of Greening Healthcare looks like, Heather's always happy to share thoughts. Again, I'm the Executive Director of Climate Challenge Network. You heard from Michael today. You've heard from Amandeep today. This team is there to support you in taking action, because we need to take action. As we've said before, at the moment, the greenhouse gas emission trends are going in the wrong direction with the healthcare sector, and it's down to all of us individually to do our part in bending the curve and moving things back on track. So, Michael, I think that's all we have for today. As always, thanks to Dan for taking the time for this, man. It's taking a lot of time for you to do what you're doing at Long Island Jewish, and but sharing this today is always more credible than what we have to say, the folks actually in the trenches doing it. Thanks to everybody for joining us, and we'll look forward to seeing you in October and hopefully again in Toronto in November. So thanks and have a great day.